Let's jump right in. Welcome to this Clinical Explainer. Today, we're diving into a high-stakes, integrative mixed block simulation focusing on facial and orbital infections. We're going to break down the precise anatomical and diagnostic boundaries between superficial infections and catastrophic intracranial extensions. Get ready, because we're going to strictly detail the intricate mechanisms, discrete management steps, and diagnostic traps you absolutely must master to excel in these clinical scenarios. Here's our clinical protocol checklist for today. First, the septal boundary. Second, the orbital breach. Third, intracranial extension to CST. Fourth, diagnostic and pharmacologic mandates. Fifth, clinical variance distinctions. And finally, number 6, our master case blueprint. Let's go. Module 1, the septal boundary. We're starting with the pre-septal matrix. So we have to first establish the superficial baseline of the pathology, right? Preseptal or periorbital cellulitis is strictly an infection of the anterior tissues of the eyelid, meaning it sits superficial to the orbital septum. It generally presents as a mild infection with prominent erythema and edema of the eyelid itself. Now, it's absolutely critical to recognize that while the exterior presentation can look super alarming, the infection hasn't actually penetrated the deep anatomical defenses of the eye. And here is the crucial point you need to identify, the absolute clinical signature of this preseptal matrix. A patient with isolated preseptal cellulitis will present with perfectly normal visual acuity and perfectly painless extraocular movements. If you ask them to truck your finger, they'll do it without any restriction and, more importantly, without deep orbital pain. This discrete physical exam finding is the absolute marker. It's what rules out deeper postseptal involvement and lets you safely manage the patient outpatient, typically with just oral antibiotics. Module 2, the orbital breach, infiltrating the deep orbit. Now, orbital cellulitis represents a severe escalation. This is an infection that has successfully breached the orbital septum. It's no longer just hanging out in the anterior eyelid, it is actively infiltrating the extraocular muscles and the deep orbital fat. The pathophysiology here is absolutely critical to understand. This breach most commonly occurs via direct spread from an adjacent paranasal sinus infection, particularly from the ethmoid or maxillary sinuses. Notice how the physical exam strictly maps to the underlying anatomy here. The discrete diagnostic markers confirming a breach include proptosis, or bulging of the eye, which happens because of the swelling deep in the orbital fat. You'll also see chemosis. But most importantly, because the extraocular muscles are inflamed and infiltrated, your patient will experience severe pain with extraocular movements, along with decreased visual acuity and diplopia. Identifying this boundary mandates immediate inpatient admission, broad-spectrum IV antibiotics, and a CT scan of the orbits to rule out an orbital abscess. Module 3, intracranial extension to CST, also known as the venous highway. This sequence brilliantly illustrates the catastrophic spread of infection, straight from the face to the brain. The mechanism hinges entirely on the fact that the facial and ophthalmic venous systems are valveless. They literally have no valves. So an uncontrolled infection of the skin in the facial danger triangle or in the ethmoid and sphenoid sinuses can travel backward. Venous blood carrying the infectious pathogen, usually Staph aureus, flows right into the cavernous sinus. And here's the kicker. Because the cavernous sinuses on both sides of the pituitary gland communicate directly via the intercavernous plexus, the infection exhibits a rapid, strict bilateral crossover evolution. Basically, what starts in one eye quickly involved both. As the infection triggers septic thrombosis within the cavernous sinus, we see the defining catastrophic signature, the cranial nerve dropout. Remember, the cavernous sinus isn't just a vein, it's a vascular pool that multiple cranial nerves transit right through. As the sinus thromboses and swells, it causes a complete crush of these transiting nerves. Cranial nerve 6, the abducens nerve, is typically destroyed first because it floats freely right in the middle of the sinus itself. Clinically, this presents as a strict loss of lateral gaze. This is rapidly followed by the destruction of cranial nerves 3 and 4, leading to complete ophthalmoplegia. And finally, you'll observe strict facial numbness, mapping perfectly to the V1 ophthalmic and V2 maxillary distributions of the trigeminal nerve. Module 4, diagnostic and pharmacologic mandates. These are your strict protocols. The imaging threshold here is an absolute diagnostic gold standard. Now, while a CT of the orbits is standard for orbital cellulitis, if you suspect cavernous sinus thrombosis based on neurological dropout or bilateral spread, a CT is no longer going to cut it.
The absolute mandate is an MRI of the brain combined with magnetic resonance venography, or MRV. This specific modality is strictly required to visualize the absence of venous flow in the cavernous sinus, which directly confirms the thrombosis. Do not be tempted by inferior imaging modalities in this scenario.
When it comes to pharmacologic management, it strictly mandates a rapid, aggressive rescue. Because we are so often dealing with direct extension from the sinuses or facial infections, you absolutely must empirically cover the most lethal organisms. The mandated protocol is broad-spectrum IV vancomycin to cover MRSA, combined with the third or fourth generation cephalosporin like ceftriaxone to cover aggressive streptococci, plus metronidazole to strictly cover anaerobic infections originating from those sinus cavities.
Module 5, Clinical Variance Distinctions, Local versus Intracranial Spread.
Okay, let's look at the clinical variance box. This maps the persistent visual boundary between a localized breach and a catastrophic spread. If your patient presents with strictly unilateral proptosis, painful extraocular movements, but absolutely normal facial sensation, you are mapped firmly to orbital cellulitis. However, the exact moment the presentation evolves to bilateral proptosis, complete ophthalmoplegia, and an unbearable headache, coupled with discrete forehead numbness, the clinical diagnosis strictly transitions to cavernous sinus thrombosis. Mapping this boundary perfectly is what dictates your next diagnostic step.
Module 6, the Master Keys Blueprint. It's time for testing deep integration.
Let's analyze the structural blueprint for this patient profile. We have a 14-year-old male with a 5-day history of acute ethmoid sinusitis. He presents with right-sided periorbital swelling, a severe right-sided headache, and a fever. Now, over the last 12 hours, his left eye has also started to swell. On exam, the right eye is intensely erythematous with marked proptosis. Now, here is the diagnostic trap. Those intense right eye findings heavily tempt the diagnosis of severe orbital cellulitis. But we have to integrate the subtle, embedded physical exam findings. The patient has completely lost sensation over his right forehead, mapping directly to V1, and is strictly unable to abduct his right eye, confirming a cranial nerve V6 dropout. Coupled with that new left eye swelling indicating bilateral spread, what is the absolute mandated next step?
We face exactly 5 distinct, highly competitive answer choices simulating actual exam conditions. Choice A, immediate orbital surgical decompression. Choice B, CT scan of the orbits. Choice C, MRI of the brain with MRV. Choice D, outpatient oral antibiotics. And choice E, temporal artery biopsy.
Let's look at the exhaustive choice-by-choice assessment breakdown. Choice A is a dangerous trap. It's super tempting for a severe orbital cellulitis presenting with proptosis, but proceeding to local surgery completely misses the catastrophic intracranial spread. Choice B, a CT scan of the orbits, is the standard diagnostic step for orbital cellulitis, but it's entirely insufficient for visualizing a venous thrombosis in the cranial vault. Choice C is correct. The student must map the bilateral spread and the specific CN6 and V1 nerve dropouts strictly to cavernous sinus thrombosis. This forcefully bypasses inferior imaging and demands an MRI of the brain with MRV. Choice D is incorrect. Oral antibiotics are totally inadequate for any postseptal or intracranial infection and are really only suitable for preseptal cellulitis. And finally, choice E is incorrect. It tests for temporal arteritis, which affects the elderly and is clinically irrelevant in a 14-year-old with a spreading facial infection.
And this brings us to our final takeaway. In high-stakes clinical simulations, isolating the precise anatomical boundary from a superficial eyelid infection to a deep orbital breach to a catastrophic intracranial venous thrombosis is the single factor that dictates your absolute diagnostic mandate. You have to keep your diagnostic protocols strict and map the cranial nerve deficits precisely. So the next time you see a swollen eye, ask yourself, are you looking at a localized infection or are you missing a catastrophic venous thrombosis brewing just millimeters away? Until our next clinical explainer, keep mastering those boundaries.